Good evening, friends. Am I audible to you? Hello. Hi. Am I audible to you? Good evening. Am I audible to you? May I know if I'm audible to you? Hi. Good evening. Okay. So, thank you, Anjali Satwada. Good evening. Good evening, Anjali Satwada. So, this session is Harrison's 20th edition based images. And remember, we'll be having a lot of MCQs as a part of this whole session. Before we enter into the session, let me tell you all the very best for your 18th of April 2021 NEET PG 2021 exam. I understand through how much of stress you all have come for this particular stage where you're coming for preparation. And this is the final frontier. And this is the area which can make a difference for the 9 to 10 months of your hard work that you have put in the last few couple of months. Remember one thing, whatever the kind of efforts you put, there will always be variant factors, external factors which can affect your performance. That does not mean the result always is because of your performance alone. Sometimes things which are not under our control may actually take control over ourselves. But our strength lies in not letting others make a difference for ourselves. We have to make a difference for ourselves. And one such stable constant would be trusting great books. For example, in case of biochemistry, going for Harper; in case of physiology, going for W.F. Gannon; in case of pathology, going for Robbins; in case of medicine, going for Harrison's. Though it's a microbiology session, I just converted the microbiology session into infectious medicine session. So let's see how many of you can actually think the answers can be perfect. Good evening, Kanchana Reddy. Thank you very much for joining us. So, do you have anything to ask me before I join, before we start the questions? If you have any questions to ask me before we join or start the session, please let me know. I'll be glad to answer your questions, because I understand some of you might be having difficulty in focusing, because though the dates have come, right now you'll be focusing on filling up the application forms. Some of you will be stressed whether you got the city of your choice, whether the city of your choice is not the first preference that the NB is giving you, or they are making you wait for that. All these things can happen, but eventually hard work will triumph, and smart work will triumph even smarter. So if you have any questions to ask me, please let me know. And this is Dr. Meenakshi Sundaram AS for you. And these are my credentials. And I have been an educator for the past 11 years. And I've also been a quiz master, so you can expect some kind of quiz questions types here, and you can see a lot of questions also. And if you'd like to subscribe to Unacademy, you can use the code Dr. ASM Live if you're coming through the YouTube channel. And if you could use this code Dr. ASM Live, you'll get 10% off on your referral code, and you'll be having exclusive access to all my free and special classes. Yes, so this is something called as plus subscription. Here you're looking at a free session here on YouTube. You'll be having multiple free sessions from me, from special classes version on Unacademy app. This is about the plus subscription. Daily live classes, structured courses, live tests and quizzes, unlimited access to all kinds of classes will be available with a referral code of Dr. ASM Live at 10% discount. And there's something called as iconic subscription, the best of Unacademy's live classes and the prep ladders, recorded videos. You can choose to have any of the pack going forward. And there is something called as Revisathon, which is a free scholarship test series for medical PG entrance exams. This is a subject-wide test. It started on 21st of February. Tomorrow it will be 28th of February, and you'll be having anatomy tomorrow. And every single Sunday you'll be having a particular subject being tested, and you can actually be the lucky winner, or you can be a hardworking winner for the scholarship. And you can have 100% scholarship for top 3 students, and you can have 10 students having 75% scholarship, and next 50 students having 50% scholarship. Here also you can use the code Dr. ASM Live if you would like to purchase the subscription. Okay, and as I have promised, from the month of March till that of your exams, till April, till you go for your exams, at 7:30 in most of the days, we'll be having free live classes on the Unacademy NEET PG app. And if you'd like to subscribe to plus classes, you can go for this. I have taken 54 hours of microbiology incomplete. That is for the sake of all purposes of exams already done. You can also have access to these kind of classes by using this Dr. ASM Live for your subscription. Okay, good evening, Ragini Rajan. So with this basic introduction, let's go for the first question. Now, I'll give you 1 minute time for every question. Please tell me what your answer is. Let me read the question for you. See, I'm going to show you the picture, but before that I want you to think about what exactly you can imagine about the picture. Diffuse maculopapular eruption. The most important keyword is diffuse over the trunk and neck, which usually resolves within 2 days, affecting children less than 3 years of age. The rash follows resolution of fever, which is similar to Boston exanthem, which is caused by echovirus 16. Febrile seizure also can occur. All these are descriptive of which of the following? Is it exanthema subitum? Is it exanthematous drug eruptions? Is it primary HIV? Or is it infectious mononucleosis? Among the 4, what is your answer? Come on, people. Excellent, ITTK. Sneha, you have given the answers as A. Okay. Anybody else with an answer? We'll see which answer fits the best. Yes, anybody else with an answer? Okay. Anita Abi says yay. Samreen Naz says yay. Kanchana Reddy says Q. Anjali Satvada says yay. Kanchana Reddy says yay. Aishwarya Karthikeyan says yay. All of you are saying yay. Excellent. So the right answer would be Exanthema subitum, and that is the right answer. Well played, people. This is just a theory to just warming you up for the pictures that we're going to look at. So what are the most important key words from the question? See, in your upcoming exam, you'll be having 200 questions, and it will be done for 3 hours 30 minutes. So imagine how much amount of time can be spent for each of the question. 3 hours 30 would mean to say 180 plus 30 approximately 210 minutes. So you'll be having 210 minutes, 200 question. It means there is more than 1 minute that can be spent for every question here. So you have enough amount of time to tackle every single question given here. And that would mean to say that does not come up with a simple idea. There'll be a catch. It means all the questions can be lengthy. So when you're trying to prepare for every single answer, that is, you're going to click the answer, read the question well, make bullet points from the question itself. So here, how do you go for it? The lesions are diffuse and they are macular and papular. That is, they can be flat or they can be a small bump. There is no vesicles, there is no involvement of fluid. And the eruptions are present all over the trunk and the neck, which usually resolves within 2 days. So within 2 days it has resolved. Children less than 3 years of age, it can happen suddenly. Tell me, what is the meaning of the word subitum, people? Exanthema means erythematous lesions that can be found on the skin. Enanthems means those who are found on the mucosa. This is a simple way of remembering it. Exanthem means on the outer surface. Enanthem means intersurface. Enanthem can occur on the mucosa. We are focusing purely on the exanthems. And what is the meaning of the word subitum? Anybody? Can anybody tell me what is the meaning of the word subitum? Come on, people. What is the meaning of the word subitum? Subitum means what? Okay, let me tell you. Subitum means sudden. Please remember, subitum means sudden. So the rashes have appeared very suddenly. Excellent. Very good, Vishwade Karthikeyan. So the rashes are resolving within 2 days, affecting children. They erupted suddenly and they can resolve suddenly. And this is similar to Boston exanthem. From this question, what can I take forward for my exams? Boston exanthem is caused by echovirus 16. This is Harrison-based information. So when you can actually expect these kind of words in the exams, you will not feel like the question is a stranger to you. That is what is my ultimate goal. If you could feel something to be feeling like it's like family. See, whenever you look at the question paper, if every single word looks at you like a stranger, there will be nervousness and panic attack and anxiety. But whenever you think that these kind of words are familiar to you, the kind of calmness you have will be indescribable. And that is the purpose of me putting forward all the kinds of new words that can actually look for. So Boston exanthem is caused by echovirus 16. This is also similar to that of exanthema subitum. Now let me discuss about the DD here. Look at this. In primary HIV infection, look at the question here. In primary HIV infection, none of you thought it can be chosen. But there is a possibility of choosing primary HIV infection when they are non-specific, diffuse, macules, papules. Look at the most important keyword here. They are also diffuse. There also can be macules and papules, but they are non-specific, and less commonly they can be urticarial or vesicular. Please understand, vesicular presence is possible in case of primary HIV. It is not generally possible in case of exanthema subitum. What about infectious mononucleosis? It is diffuse and maculopapular lesion, of course, but urticaria will be very serious. Petechiae can be seen in some cases. But in infectious mononucleosis, the skin eruption has one important property. There can be edema, and it can be mostly periorbital edema, and in the palate you can have petechial hemorrhages. I repeat, in the palate you can have petechial hemorrhages, and the other clinical signs and symptoms of severe infection can be seen: heterosplenomegaly, pharyngitis, cervical lymphadenopathy, atypical lymphocytosis, heterophile antibody test being positive. All should be token to you. They should be in mentioning all of these things if I have to choose infectious mononucleosis. So none of you would have gone for D. And the possibility of you choosing C is also very poor, because generally don't think primary HIV is capable of causing skin lesion, but know it. Primary HIV can cause diffuse macules and papule skin lesion. Now, what is the next one that you have to rule out? Exanthematous drug eruptions. What is the most important keyword? They should give you a history of drug, and they have to be intensely pruritic. Here, we have not spoken about a lot of pruritus. Please understand, pruritus is a very, very important word that you have to mention in case of drug eruptions. There is something called as drug eruptions with eosinophilic property. So eosinophilia will play a major role if there is a drug eruptions, and they can be target lesions if possible. Also look at it, they can be present symmetrically on the trunk and on extremities. They can become confluent. For example, a lesion is here, here and here and here. Suddenly if some kind of barrier happens and the bridge happens between them, all the lesions can come together to become a single confluent lesion. This is possible in case of drug eruptions, not in case of exanthema subitum. Also, it can occur any time, even shortly after drug is discontinued. This is the most important keyword, but at least once they should have spoken about a drug. And next thing is about exanthema infectiosum, and it is also called as what? Slap cheek appearance. Can anybody tell me what is the causative of slap cheek appearance? Can anybody tell me what is the other name for, what is the causative of slap cheek appearance? Anybody? Excellent, Aishwarya Karthikeyan, Sneha. It is Parvovirus B19. Very good. And when will that happen? It generally happens in the winter and spring. What can you expect? Mild fever, arthritis in adults, and rash following resolution of fever. Generally, in case of infants or children only, you can have pancytopenia because of bone marrow depression. In case of adults, you can have small joints polyarthropathy. Small joints polyarthropathy should be spoken about. Only then you can think of exanthema infectiosum becoming very serious because of parvovirus B19. So in this case history, in case of erythematous drug eruptions, they have not spoken about drug intake. In case of primary HIV, they have not spoken. In case of infection mononucleosis also, they have not spoken about the systemic manifestations. Okay, this is a simple question to begin with. Now let's look at a picture here. Now look at the picture. False about the causative pathogen of the given picture. The causative pathogen infects the T cells by binding to CD46 receptor. It has two variants, 7A and 7B. In children, it causes sixth disease. In older age group, the causative is associated with mononucleosis like syndrome. Among the following, which one is false? I'll give you 1 minute time. Go for it, people. Correct, I30K, Sarvesh and Dr. Priya. All of you are correct. Very good. Yes, what is your answer? Take your time. Another 30 more seconds. do you think is the right answer for this question? What is a false statement? A, B, C, D. Which one? Apurva Singh says A. Dr. Priya says C. Anybody else with an answer, people? There is no poll, Shobhan Mandal. You can just give me an answer here. This is not a quiz contest. This is just like, this is not a quiz contest. You can just give your answers on the same section here. Okay, Shobhan Mandal says B. Okay, now for this statement, okay, Mainavati Murli says A, Aityatik K says A. Okay, now tell me what is the condition here first place. So let's wrap up with the answers here. Tell me what is the condition here, what is the diagnosis? Look at the person here, adult or a child? By looking at the picture, what can you make out? Is it adult or a child? No, Apurva Singh, this is not called as lacy reticular rash. That is why I have put you into a thought process. See, this is not the lacy reticular rash you're looking at. Anything else? See, I would want you to focus here, 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 and these areas, and some rarely in these areas. Okay, child. So what is the diagnosis, people? First, let me, what is the diagnosis? In the given condition, what is the diagnosis first? Tell me any diagnosis. For example, you can say measles, rubella, rubeola. You can say exanthematus, exanthema infectiosum, exanthema subitum. All these things. Tell me what is the diagnosis first. See, we'll discuss it threadbare. Just tell me what is the diagnosis. I'll give you the answers for every single option. I will tell you why every single option is the right option or not. So don't worry about it. Just tell me what is the diagnosis first, please. Put your thought process forward. See, okay, Shobhan says it is rubeola. It is not rubeola. Anybody else with an answer? See, make all your mistakes in the classroom. The more you sweat in the practice field, the less you will bleed in the battlefield. Do not feel shy in giving out an answer, because I have not conducted this as a quiz contest, as a poll. This should be more of a discussion also. All of us should understand each other. And it is not necessary that I'm always right. A teacher may be wrong also. I accept the fact. On that basis, I would want to put this forward as a discussion, so you can give me an answer. Okay. So Aditya says exanthema subitum, Akash says HSV, Aishwarya Kartikeya says roseola, Deepika Ravi says measles. Okay, so let's start with the understanding of the diagnosis first. See, this is HHV6, this is exanthema subitum or roseola infantum. So it can be both. It can either be called as exanthema subitum or roseola infantum, but you generally call it as sixth disease. You call it as sixth disease. Yes, the picture is not so clear. Let me tell you, none of the pictures are my responsibility. I have taken them from Harrison's Infectious Medicine. There is a classical textbook called as Harrison's Infectious Medicine, and I have picked up directly the pictures from there. So this is to show you that these kind of pictures can be there in the exams, which may not be clear in the exams also. Yes. Now look at this part here. This is sixth disease. And how does the sixth disease progress? It is caused by HHV. Akash Trivedi, you came so close. It is not caused by HSV. Why? See, HSV can be 1 and 2. What are they technically? They are HHV 1 and 2. HHV1 is HSV1, HHV2 is HSV2. What is HHV3? It is varicella zoster virus. What is HHV4? It is Epstein-Barr virus. What is 5? It is cytomegalovirus. Then we have HHV6, and then we have HHV7. This HHV7 is also called as RK virus, and HHV8 is also called as Kaposi sarcoma virus, while HHV6 is human B-cell lymphoma virus. Now this is HHV6. This infects T cells by binding to CD46 receptor, and that is absolutely a true statement. It has two variances, 6A and 6B. It is not 7A and 7B. This can be the simplest mistake that you can actually slip forward with. Do not fall for simple questions. Do not fall for simple things. Now you might have thought that why exactly this question is so difficult. A picture is just a visiting card for you to enter into a question. That question need not have any responses related to the picture at all, but the question stem may be related to the picture. So what is happening here? See, first you should make a diagnosis. then you should be sticking strongly to the diagnosis. Second, you have to understand what the question is asking you. Then you have to relate the diagnosis with the options given to you. Then you have to rule out the options keeping the organism in mind, which is the reason behind the diagnosis. Only then your answer can be complete. I'm really sorry for those people who have chosen A but they got it wrong, because people might have thought that I would have kept a trick or two in case of T cells. Please remember, this is going to attack your T cells, no question about it. It is called a sixth disease because the rash happens on the sixth day, and older age groups the causative is capable of causing mononucleosis syndrome. So remember one thing, there are three organisms that are capable of causing mononucleosis. One is Epstein-Barr virus and the next one is cytomegalovirus. But your HHV6 is capable of causing infectious mononucleosis like syndrome. This is what I want you to carry forward. One information you have learned forward. Now let's go for the next question. Next picture. Look at this picture here. Look at this picture here. This is on a child and this is on an infant. What you're seeing here is on the infant. This is on the child. Focus here. Focus here. And this is on the infant's bum. Okay. Now look at the question here. Now look at the question. The true statement about the given picture, caused by a persistent bacterial infection, caused by a non-enveloped virus with icosahedral symmetry, possesses circular double-stranded DNA, infects humans after being acquired from the animals. So among the following, which one is true? Okay, Mozam Haider says EBV, Aditya TK says Parvovirus B19, Akash Trivedi says scarlet fever, Mozam Haider says EBV again, and Shobha Mandal says erythema infectiosum. Aishwarya Karthikeyan says no, the answer is B, she says. Shobha Mandal says A, Nitin Selvam says C, Sayanthan Basu says B, Kanchan Reddy says B. Any other answer? Okay, so what is your diagnosis here, people? Yes, what is your diagnosis right now? Asavari Bide, very good. B. Akash Trivedi, very good. C. You're saying A. Okay, Manasa Anonymous, C. Parvo. Okay, so Manasa says it is C. Parvo. Okay, Aditya TK says B. Shobhan Mandal says B19. Okay, Deepika Ravi, Dr. Priya, Aditya TK, all of you. Excellent playing, excellent playing. So, what I told you here just now is, when it comes to picture-based questions, looking at the picture is an art of itself. You should have exposed yourself to so many pictures that you will not be confused in the day of exam. So obviously all of you are able to say it can be something related to the erythema infectiosum, but if it is erythema infectiosum, you should know what is the causative organism, which is Parvovirus B19. That is only covering 50% of your attempt. The 50% remaining attempt happens on the question itself. What is the true statement about the given picture? Is it caused by a persistent bacterial infection? If you are very sure it is Parvovirus B19, then option A is wrong. Now look at this one, D. Infects humans after being acquired from animals. If it is Parvovirus B19, it is spread from human to human. It is spread from human to human. It's not a zoonotic illness. Please mark my words. It's not a zoonotic illness. So nobody had difficulty in choosing D. But the problem is between B and C. So caused by a non-enveloped virus with icosahedral symmetry, possesses circular double-stranded DNA. These two things should not be a difficulty at all if your theory is very strong about Parvovirus B19. What have we discussed in case of virology? Just 10 days back, we have discussed complete microbiology. I had told you many times, and even in special classes, I have told you, Parvovirus is the only DNA virus which is a single-stranded DNA virus. I repeat, Parvovirus has many special properties. It is the smallest DNA virus. And to top it, it is the smallest virus at all. It is the smallest virus attacking human being, and it happens to be a DNA virus. It is so small, it does not have space for two strands. So it's a single-stranded DNA. And if it's a single-stranded DNA, then obviously option C is wrong, D is wrong, A is wrong. You have to focus on option B. And think about it. Icosahedral symmetry indicates what kind of virus generally, from whatever logics I have taught you. Tell me. From whatever logic I have taught you in my classes, tell me, icosahedral symmetry is a property of which viruses? Icosahedral symmetry is a property of which virus? Correct, Nathan Tamilson. It's a small single strand. Correct. Yes. Icosahedral symmetry is a property of which kind of virus? So let me tell you, if at all I have to go for DNA virus versus RNA virus, you have to know certain rules. Please follow these rules for all your interesting preparations. You will never go wrong in these rules. Rule number 1, in case of DNA versus RNA viruses. DNA viruses can show icosahedral symmetry. RNA viruses will show helical symmetry in general. And DNA viruses are double-stranded in general. RNA viruses are single-stranded in general. DNA virus replicates in the nucleus, while RNA viruses RNA replicates in the cytoplasm. These are the most important differences you have to know. But whenever I draw any kind of rules, you can always expect exceptions. So the exceptions to the double-stranded DNA would be Parvo, which is single-stranded DNA virus. The exception to the RNA viruses of single-stranded is Reoviridae. What is Reoviridae? You can have rotavirus family and echovirus family coming in this area. These are double-stranded RNA viruses. Also remember, all DNA viruses are icosahedral symmetry except pox viruses who have a complex symmetry called as box symmetry. Complex symmetry called as box symmetry. And all RNA viruses will replicate in the cytoplasm except that of HIV, which can replicate in both cytoplasm and that of nucleus because of the presence of your reverse transcriptase. All DNA viruses replicate in the nucleus except hepatitis B, who can replicate in both nucleus and that of cytoplasm. I hope you'll be able to use this information. Did you understand this picture, people? See, to answer such things, some basic things should be very strong for us. That is why I told you. Is it okay if I teach you all these things, people? Pox virus does not have icosahedral symmetry. Pox virus has a very complex symmetry called as box symmetry. Otherwise, generally DNA viruses will have complex symmetry. Okay, are you all able to understand this? Okay, so the right answer is B. It is caused by a non-enveloped virus. It has icosahedral symmetry. So when I say icosahedral symmetry, I understand it has to be a DNA virus, and parvovirus is a DNA virus. The only exception is that replicates in cytoplasm pox. See, pox can happen to replicate, but the core nucleus happens because there is a complex symmetry. You will not be having differentiation between that of nucleus and that of cytoplasm. It can happen anywhere. So it is not taken into consideration for either the rule or the exception of the rule. Okay, now look at this part. Erythema leading to slap cheeks appearance in erythema infectiosum caused by Parvovirus B19. Look at the keywords here. Lacy reticular rash. This is what I want you to focus here. Let me erase all the annotations. You can see it very clearly here. If you notice this, can you notice the rashes moving like this? These are called as lacy. And what is meant by reticular? Reticular means a network. So you can watch them forming a network here, here and here. This is the lacy reticular network of pattern that can be seen in case of Parvovirus B19. That is what I'm explaining, Apurva Singh. Are you able to understand this, Apurva Singh? Yes, please focus on this zone and on this zone. They are laced, very thin lined, and they are reticular because they are going for complex networking. Is that okay? Now let's go for the next question. This is the smallest of viruses, 18 to 26 nanometers in size. Okay. Now, all the following are seen in the given condition except, look at the given condition here. All the following are seen in the given condition except, which statement is a false statement? Come on, people, which is a false statement here? It takes a lot of guts to make a commitment to say what exactly is the diagnosis, even if it is wrong. So please be brave, please be bold. I told you, right, commit all your mistakes in the class so that you don't make the mistakes in your exams. The pictures are unclear, of course, but this is how the quality of the pictures will be there in your exams also. Yes, okay, so Apurva Singh says C, Sneha says D, Deepika Ravi says B, A, D, C, B, A, okay. Okay, so can you tell me what is the diagnosis first? What is the diagnosis first? Can you please tell me what the diagnosis is? Okay, Aishwarya says A. So many people have ended up by saying A. Okay, some are saying C. Okay, so this is one of the tricks I would like you to understand very clearly. Okay, so Kishore says B. Okay, rubella, measles, excellent. So remember one thing, whenever they're giving you a condition in the stem of a question and they're giving you responses in the form of the features, the most common feature which can be manipulated for your questioning, the most important feature which can be manipulated for questioning would be the feature that is based on numbers. Please understand one thing, the easiest way of picking a false statement, for example, if I ask you to make a question and you are making a question with a stem, and the responses, if you're going to ask for a wrong part of the question, I'm asking you to choose or pick up the wrong statement in the given 4 options, then the easiest way of manipulating would be that statement which is filled up with numbers. So here the one that is filled up with numbers is incubation period less than 10 days. I'm not saying it is always genuinely true and always works. I'm saying it most commonly works. So in this question I have framed it in such a way, you're looking for a false statement. So I will be picking up 4 standard statements and I twist only one statement to get it as a manipulation. That manipulation is easy if it is based on numbers. It is just a human psychology. If at all you know nothing about the question, then you can go for it. So now I'm able to understand the diagnosis being made. The diagnosis rubella. I'm very proud of your answers. Who all have given me the answers? Okay, let me tell you. Aditya, Aditya, Shobon, Prakash Yadav, Nawang, Abhirami, Sneha, Sayanthan, Ramu, Apurva Singh, Dr. Priya, all have given the right answer. Of course, it is rubella. So, in case of rubella, what is definitely known, if at all the rubella is causing a congenital infection, then cataract can be expected. Cataract, mental retardation, deafness can be expected in case of congenital rubella. And if it is rubella, please understand tender lymph nodes in the neck can be a very important feature. Lymph adenopathy is definitely strongly positive in case of rubella because these viral infections can go through your lymphatics, and in the lymphatic area the aggregation, see, imagine if the lymphatics are like the train tracks, where the train tracks stop for an accumulation in the railway stations. The railway stations will be the lymph nodes while the tracks will be the lymphatics. So when the virus or filarial worms are also traveling to the area, lymph nodes is what we can focus on, and the adenopathy will be tender because the virus is capable of causing insane amounts of proliferation. Proliferation is very faster, and when the proliferation is faster, the lymph node covering or the capsule can be slightly stretched. The stretch is the reason for the tenderness. And also remember, causative pathogen is an RNA virus, 100% true, because measles, mumps, rubella, all these are killer diseases of childhood and they're capable of being RNA viruses. Okay, so look at the other statement here. It can be present partly in the occipital and the post-auricular area. Occipital and post-auricular areas are the most common areas where you can have the lymph node that is being tender. And what is the incubation period of rubella? It is 14 days. Remember, approximately 2 weeks. It can extend up to 3 weeks. It is not less than 10 days. It is never less than 10 days. Rubella can be a very slow thing. If, for example, if a child is not vaccinated, that child would have been exposed to another rubella case more than of 10 days for it to show manifestation. If it is for less than 10 days, the lesions will not have happened. And what kind of RNA virus is it? It belongs to Toga viridae. This is what I want you to remember for your exams. Let's go for the next picture. Now this is the given picture. In this given infection, window period indicates what? In this given infection, comma, window period indicates what? A, B, C, D. Go for the option, people. We'll see how many of you can get it right. In this given infection, the window period indicates what? Let me move away so that you can read the options properly. Okay, many of you have said A. The last line says time period between infection and maximum multiplication of the agent. Okay, so the class is split between CAB, AAA, BAA, B. Any other answers, people? A, B. Okay. B. Okay, any other answer? We have 15 more seconds. B, A, B, A. Excellent, excellent. Okay, so with this, we'll log the answer as B. Okay, we'll log the answer as B. B is the right answer. Before that, tell me what is the diagnosis? What is the diagnosis, people? Tell me what is the diagnosis? Yes, I understand. Now, let's not think about the answers more and more. Tell me what is the diagnosis? Come on, people, what is the diagnosis? Try giving any answer for that matter. Doesn't matter. Give me any answer that comes to your mind. Okay, Lakshmi Singh says measles. Any other answer? See, I will stick to my promise. I made a promise, right? I will definitely teach you at least something new for every single session I sit with you. And it is a very guessing, okay? It's a very concerted effort and it's a very conscious effort to bring you something new that you have not known before the exams. Anybody else? Okay, so the answers I have gotten is measles, chickenpox, measles, rose spots of typhoid, Kaposi, rose, measles, Kaposi, typhoid, bacillary angiomatosis. Excellent. Many things have been the right answer, but this is, okay, let me tell you the diagnosis here. This is primary HIV infection. And the lesions are what? Anybody remembers from the previous topic? This is a classical case of primary HIV infection. You wouldn't have expected in your dreams. The point is, yes, hello Rahul Soni, very good evening. Akash Trivedi, is not measles. See, measles is called as a morbilliform rash. Morbilliform rash will be punctate lesions coming out everywhere. This is not a punctate lesion. This is not morbilliform rash. This is the rash of primary HIV infection. None of you would have actually generally thought of primary HIV infection. Do you remember the first question we discussed? In the first question, I spoke about primary HIV being a part of your differential diagnosis in the given question. In this given question, diffuse maculopapular eruption of the trunk and neck, which generally resolves within 2 days, affecting children less than 3 years. Why did I rule out option C? Because primary HIV infection acquired because of HIV would not be attacking children less than 3 years of age if it is because of sexual transmission or bloodborne transmission. Generally, it attacks adults. But definitely in HIV, I can expect diffuse macules and papules. They can be less commonly arterial and versicular, I told you. Here, I am just showing you the real-time picture in adult. An adult who got a real-time HIV because of poor sexual practice or poor hand hygiene or by needle hygiene, he would have accepted this. Excellent. This is called as primary HIV infection. This can be macular or papular. It can also be taken as yes, correct, purpuric. Now look at this. Now listen very carefully. There are two important words which can confuse you. Option A is about incubation period. The time period between the infection and the onset of first symptoms is the definition of incubation period. But window period is what? Is it important for diagnosis or for investigations? Tell me, people. Window period is the word useful for. Window period is important for what purpose? Anybody? When will you use the word window period? See, when you want to make a diagnosis based on physical examination, you do not come across the word window period. But when you want to make a diagnosis based on investigations, you come across the word window period. Excellent, excellent. Or investigation. So, what is the point here? See, when I try to take blood from the patient and I go for investigations, neither the antigen nor the antibody will be available. So, time period between the infection and the detection of the antibodies against the causative agent called as HIV is referred to as window period. Why am I telling you this? Excellent serological diagnosis. Very well played. Now look at this part. See, when a patient has acquired HIV for the first time, in the first 1 or 2 weeks, you can always go for P24 antigen testing, which can most probably tell you whether he is infected or not. But after that, the P24 antigen wanes off. When this antigen removes away, before the antibody is formed, there is a small period. That period where I can't look for the antigen or I can look for the antibody, that period is called as window period. So window period is the time period between the infection and detection of antibodies against the causative agent. Now look at option C and D. They don't fit our purpose. So the right answer is B. So let's go for the explanation here. The window period is this. It takes 2 to 8 weeks to months for antibodies to appear for HIV infection. This period is called as window period of seronegative infective stage. I look at the most important keyword here. It is seronegative infective stage. This is how you can define the window period in case of HIV. Seronegative infective stage. And during this period, individual may be highly infectious, and you can go for P24-21 antigen assay and PCR for the virus itself. Okay, now let's go for the picture here. Now tell me, what is the diagnosis? This is not an MCQ. Let's take it as a discussion. I have given you. Thank you very much. Okay, now look at this picture here. I have discussed about this already. Tell me, what is your diagnosis based on the prior discussion? Based on prior discussion. Now let me help you with this. See, we had a discussion, right? This is the slideshow where we had the discussion, and your diagnosis can be based on this slideshow. Have a look at the slideshow. So your answer can be one among them. 1, 2, 3, 4. Among the 4 is the answer. Tell me, what is your diagnosis? Anybody for that matter? Okay, so you have gone through it. Look at this. This is the picture here. What is the diagnosis now? Okay, Aditya Tikki and Aishwarya are saying it is drug eruptions. Kanchana Reddy also says drug eruptions. Shobhan Mandal says Exanthem is drug eruption. Lakshmi Singh says infectious mononucleosis. No, Lakshmi Singh, it is very far away from that. Ragini Ranjan and Kishore, Maya Inavati, Murli, all of you are saying drug eruptions. Excellent. So, what is the most important point? Now, what do you understand from here? This zone tells you what? This zone tells you what? Which was the key word I was talking about? Yes, correct. All of you are right. It is drug eruption. Tell me, what is the keyword that this area is actually focusing on? I told you to focus on one keyword, right? Anybody? Yes, it is exanthematous drug eruption. I understand. This is exanthematous drug eruption. Absolutely understandable. But tell me, what is the keyword I'm showing you in this picture? I have drawn certain zones, right? What is the importance of the zone? Coalescing lesions. Excellent, very good. But more than coalition, you can use the word confluence of lesions. They all have come together. Now, if you look at it in a zoomed way, see, this is a dot. Now, watch very carefully. See, this area can be a dot. This area can be a dot. This area can be a dot. But all the dots have come together. They have gone for confluence. So confluence can be the most important property of looking at exanthematous drug eruptions. So look at the part here. Brightly erythematous macules and papules, some of which are confluent. They are distributed symmetrically on the trunk and extremities. Look at this. They are present on both the sides without showing much of a deviation. They can be present equally on both sides. They are symmetrical. So the key words here are, they are symmetrical. In this zone, they are non-confluent. In this zone and in this zone, let me use a different color for you. In this zone and in this zone, we are looking at confluent lesions. And all of them are bright. And they are symmetrical, non-confluent and confluent, and bright macules and papules. They are not elevations. I repeat, not much of eruptions, or not much of elevations. They are just macules and papules, no vesicular activity or no pustular activity. Okay, now look at this. This patient presents with splenomegaly, leukopenia, fever. Most important words, splenomegaly, leukopenia, fever, and died in a few days. Longitudinal ulcers in the intestines were noticed. Drug commonly used against this or all except. Go for the options, people. Now you have 60 seconds to answer. Make a diagnosis and come for the answer. Dr. Shravani Prasad, yes, it can be hemorrhagic. It may not be it may be non-hemorrhagic also. Yes. Okay, Aishwarya says A, Ragini says B, Apurva says A, Lakshmi says A, Kanchana says A, Prakash says diagnosis, Sneha says A, Mukesh says A, Aditya says A. Okay, Apurva says typhoid, Prakash other says A. Okay, so you're saying it is typhoid. What was your basis for calling it as typhoid? Anybody? What are the things you have to notice for typhoid? You are saying typhoid, understandable. What made you choose typhoid? Okay, so Shobhan says D. Any other answer? Tell me, why do you call it as typhoid? Why typhoid? Okay, so most of you are pinning your answers based on longitudinal ulcers. Very good. That's the way you can be sharper. Not a problem at all. When I say longitudinal ulcers, you think of typhoid. If it is transverse ulcers, what do you call it as? Transverse ulcers, what is the diagnosis, people? Excellent. Yes, Prakash Yadav is even more deeper thinking in terms. He's saying splenomegaly and leukopenia. Understandable. Just give me answer. Transverse ulcers. If it is longitudinal ulcers, it is typhoid. Transverse ulcers means what is the diagnosis? Excellent. TB. So now we have ruled out TB. Just a minute. We have ruled out TB part. I'm erasing all the annotations here. So the most important keyword is splenomegaly. Splenomegaly indicates what? Splenomegaly just indicates increase in the size, increase in the numbers of reticuloendothelial system, that is called as macrophages. If macrophages are increasing in size, then what kind of organism are we talking about, or at least which stage of the organism are we talking about, intra or extracellular? I'm saying splenomegaly is right now noticed. Now there is an increase in size and numbers of the reticuloendothelial system, that is macrophages. So when macrophages are increasing in size and number, it indicates macrophages are in the direct war against the organism. If the macrophage is fighting against the organism directly, what kind of organism are we talking about? Are they showing extracellular existence or intracellular existence? Intracellular. Why? Because if this is the organism and if this is the macrophage, a macrophage tries to swallow the organism. After swallowing, what happens? The organism is not able to digest the organism instantly. That is why the organism is intracellular. Imagine the purpose of an organism to be captured by the macrophage is to internalize and digest. But if the macrophage is not able to digest the organism starts increasing in numbers. When the organism increases in number, to counter the organism, more and more macrophages are used. So there is an increase in size, increase in number. But because the organisms are increasing, every organism has to blow up, every macrophage has to blow up in size. So it can be increase in size. So macrophage can have increase in size, increase in number. That is the reason for splenomegaly. And please remember, in any other kind of typical infection or pyogenic infections, you can expect neutrophil levels to increase. Neutrophil levels can increase. But in case of typhoid, neutrophil levels will start decreasing very rapidly and it can lead to total leukocyte count also falling. So when you say leukopenia and splenomegaly, think of typhoid. When I use the word longitudinal ulcers, your typhoid thought process can be even more accentuated. But what are these lesions I'm looking at here? Excellent. You are saying enteric fever. Understandable. Dr. Priya, this is not extracellular infection. This is intracellular infection. What is these lines? What are the lesions telling you about? Come on, people. What are the lesions pointing towards? What are these lesions about? Excellent, Kanchana Reddy. They are the rose spots. Now tell me, rose spots can be noticeable in what kind of skin? Rose spots are noticeable in what kind of skin? Anybody? Yes, you don't use the word pink spots, you call them as rose spots, but understandable. Yes, no, not bacterial emboli. I understand bacterial emboli can be causing such lesions, but rose spots, tell me what kind of skin? The skin should be fair or white. It is not seen properly in dark skin. Okay, so what am I showing you here? This is a fair skinned person. On him the rose spots are easily available to be noticed. But if it's a dark person, then you can't rely on rose spots. You have to go for the theory. Okay, so now I have told you very clearly, this is a case of intracellular infection. So most of the organism's presence, if it is present in the blood also, it is traveling along with the macrophages. It can be present inside the cell. Now which drug is contraindicated or not used? Amikacin. Why? Because amikacin is a highly ionic drug. Why? Because amikacin is an amino glycoside. The presence of the amino group can render NH4 plus coming out into the equation. If any kind of drug is highly ionic, it won't be able to cross the membrane. It will not be able to go across the membrane. It gets repelled by the membrane. So amikacin will not be effective against the organism because the organism is mostly intracellular. The drug will not penetrate into the cells. That is the reason why amikacin has not been used. Dania Fatima, hi. Okay, so did you all understand the explanation, people? Can I go to the next question? Please let me know. Hello, Dania Fatima, you're in class 5, such as cute child. Child, please don't see these pictures. These pictures can be horrible. These are infectious conditions. It can be very horrible. For the child of your age, it will not be appropriate for you to see it. So skip this picture, skip this video and go for some other videos, okay? Yes, so let's go for the next picture here. What do you understand from this? Make a diagnosis. Clue: non-infectious, but can be triggered by infections. One more information. Not drug eruptions. Okay, so Parth, Bhavsar, Kishore, Sneha, Sujit Kumar, Raj Kansha Reddy, or no, this is not parvovirus. I understand you thought of the slap cheek appearance, but this is not just a slap cheek appearance. It is present on the nose also. This is the difference. For those people who are seeing it for the first time, there is a possibility it can happen. Okay, dermatomyositis can be showing you shawl lesions. It can be present on the shoulders also. Let me try to compare this picture with that of your slap cheek picture. In slap cheek picture, the involvement of the nose is uniform and not as dark as what you see on the skin that is present on the cheek area. This is slap cheek appearance, but you can't see them much happening in any of the other areas. You can see this as the difference. Here you will see this area is completely uninvolved. So this is systemic lupus erythematosus. It can become discoid lupus erythematosus if drug involvement can be noticed. Okay, this is prominent malar erythema and minimal scaling. Scaling is almost nil. That is how you differentiate between that of your slap cheek appearance on that. And mostly it is happening on the sun exposed areas. Okay, gutter sign can also be noticed. Okay, now let's look for the, yes, butterfly rash. Very good. All of you are really good. I just introduced this picture to make sure that you can have a variation from the infectious condition. Again, going back to infection, all are true about the pathogen except if this is the pathogen. See, this is the condition. Think about what can be the organisms can cause this condition and pick up one organism and try to focus on all the 4 options and tell me what is the right answer here. Which one is a false statement? Yes, go for it. Correct, Abhinay Gultne. Okay, WhatsApp only says HSV1. Does it look like HSV1? Look at the child here. Mostly HSV1 is spread through kissing and also by sexual intercourse, and it can happen by mild touch, but it won't be very severe in the oral cavity in terms of a children. It's almost like an infant. Transduction. What are you saying? Transduction. Oh, okay. So you're giving the answer for option D. Okay. Anybody else? Okay. So I am receiving a lot of options. I'm seeing D, B, D, C, D, D. Yes. Okay. D, B, C, C, C. Okay. All of you are saying it is impetigo. Excellent. Now, can you tell me what is this color? Can you people tell me what color is this? This area? Okay, excellent, Ramesh Kaur. You're saying it is staph aureus and impetigo, acceptable. Any other? I'm asking you for the answer. Okay, so most of you are saying the answer to be either B or C. Okay, understandable. Let me erase all the annotations for you. Yes, you're saying B, C, D. Okay, anything else? No, Ramu, this is not golden. Okay, Ramu, you're very funny. I actually drew the picture for you. See, I wanted you to notice this central color. Excellent, Manimegalai, Prakash Yadav, and Akash Trivedi, Kanchan Reddy, Shobhan Mondal, Prakash Yadav, Aishwarya Karthikeyan. Excellent. These are called as honey colored crusting. Honey colored crusting. If it is honey colored crusting, it can either be called as impetigo contagiosa or it can simply be non-bullous. And if it is contagiosa, the most contagious type of impetigo can be Staph aureus. Remember, there is always a confusion. People think impetigo can be caused by Staphylococcus aureus as the most common thing, but no. Impetigo's most common cause is always Streptococcus group A pyogenes. The most common cause of all impetigos will be Streptococcus pyogenes. If I say contagiosa and if I can notice honey colored crusting, then I can think of Staphylococcus aureus. Now coming back to the topic here. Resistance shown by the agent to methicillin. Methicillin resistant Staphylococcus aureus. You are saying transduction. Understandable. That is why you are choosing D, but that is not about methicillin resistant, it is about penicillin resistant Staphylococcus aureus. I repeat, Staphylococcus aureus multi-drug resistance began with the concept of transduction, but when you come to methicillin resistance, the most common change can be chromosomally mediated, and option D is absolutely true. And epidermolysin is also referred to as staphylococcal scalded skin syndrome toxin, and that toxin is definitely a superantigen. And 30% of general population is healthy carriers. Of course, yes, the organism can be present in the anterior nares and in the oral cavity and in the nostrils of 25 to 30% people. Absolutely true. But what you actually missed out on this is, look at the option here. Most common source of infection is cross infection from infected persons is wrong. It is cross infection by the hospital staff who are not infected people. Non-infectious people are the most common sources of transmission of the infection. That is what you have missed. That is why I wanted to keep your thought processes open. The right answer is option A. Did you all understand why the answer is A? Because infected people affecting infected people is not a big deal. Because for example, I'm suffering from infection and lying on the bed. Another bed person will not be coming in contact with me. But the hospital staff, when they come and touch me and then they go and touch another patient, the hospital staff are actually healthy people, but they are the source of infection. So cross infection is not from infected people, it is from the hospital staff who are healthy people. So this is the reason why option A is the wrong answer, but everything else is absolutely true. Resistance shown by agent to methicillin is chromosomally mediated, but if it is penicillin binding protein being altered, then that can be by transduction and conjugation. Lakshmi Singh, here we are focusing on this epidermolysin as a part because I understand it is Staphylococcus aureus. And why have I chosen Staphylococcus aureus? Because of honey colored crusting. So the answer here is Staphylococcus aureus, and your answer should be chosen based on Staphylococcus aureus. Let's go for the, okay, look at the theory part here. Anterior nares, skin of perineum, axilla, groin areas are the most common sites of colonization. Superantigens of Staphylococcus are toxic shock syndrome toxin, epidermolytic toxin and enterotoxin. That is, Staphylococcus aureus is the most common cause of food poisoning in general, and the source of food poisoning is dairy products. Please understand, dairy products does not mean unpasteurized milk. Unpasteurized milk speak about the raw material called as milk, but the milk has been processed, then it has been converted into dairy products like ghee, butter, etc. From there you get Staphylococcus aureus as the most common source of food poisoning, and that area it is caused by enterotoxin. This enterotoxin, if it is present in the GIT, it causes the most mildest symptoms. But if it is entering into blood, then it can become a superantigen. So, toxic shock syndrome toxin, epidermolytic toxin called as Staphylococcal scalded skin syndrome toxin, and enterotoxin are the three important superantigens. I hope you'll remember this for your exams. Yes, cheese, curd also can be taken into consideration. Now look at this picture here. Let's go for the next picture. Now all of you have a look at this picture. Excellent. Okay, Mani Meghalai says meningococcal, Akshat Trivedi says HSP. So please remember, Hinox condyline purpura does not necessarily mean it is always infectious. It can be non-infectious also. But infections can always trigger Hinox condyline purpura. Now some people are saying meningococcal, some people are saying HSP. My point is, just describe the lesion first, then we go for diagnosis. Okay, have you looked at the lesion now? Now look at the lesion. Now look at the question. Pick up the true statement. Most severe form with systemic involvement in this group of causative organism is seen in this condition. It takes a lot of efforts for you to understand option A. Please try to understand option A. Most severe form with systemic involvement in this group of causative organisms is seen in this condition. Which condition? This condition. What is seen? The most severe form of systemic involvement is seen in this condition. It is caused by Coxiella burnetii. 10% cases have the rashes on the extremities which are hemorrhagic, spread by the bite of a mite bite. Okay, spread by the bite of a mite. So among them, pick up the true statement. A, B, C, D. Abdul Yusufzai says palpebral purpura HSP. When will you say palpebral? Now watch it. Is it looking elevated? Look at the lesions and tell me, are these lesions looking elevated from the level of the skin? Are they elevated from the skin level? No, they are not elevated, so you can't call them as palpebral purpura yet. That is why HSP has to be kept under consideration before I choose it. Okay, good. Cyrilla Velanki, very well played. Vasculitis. Okay. Okay, so now let's stop with the incoming answers. Now no more answers. You don't have to tell me the answers anymore. Now tell me, what is the diagnosis? Many people have said meningococcus. Did any of your option think about meningococcus? No. Next, you said HSP or palpebral purpura, but I told you it is not palpable because it is not elevated from the skin lesion. Okay, so I don't take this. Now, from the given 4 options, make another diagnosis. Excellent, Shobhan Mondal, he thinks of rickettsia. Akash Trivedi, you're thinking of Q fever. Please remember, Q fever is the only rickettsial infection. Okay, it's the only rickettsial infection without a skin rash. Without a skin rash. And that Q fever is caused by Coxiella burnetii. Because this case is a classical skin rash case, then option B is absolutely wrong. Option B is wrong. Are you following this part? Excellent, Patsahani. There is no rash. Yes, rickettsia. It is not Lyme's disease. Please understand, Aishwarya. The Lyme's disease, for example, if I draw the skin here, the Lyme's disease will have a particular lesion like this. At the central area, there will be a dot. There will be a target sign. What is the target sign? You will be having alternative light, dark, light, dark patches of the central spot. It is called as target sign, and this is called as erythema chronicum migrans. This is not borreliosis. This is not caused by Borrelia burgdorferi, but you are looking at petechial hemorrhages everywhere, and these are not palpebral. This is a rickettsial condition. Name excellent Manimegalai. Ultimately, she has come to the right answer. Manimegalai has given the right answer. It is Rocky Mountain Spotted Fever. And in case of Rocky Mountain Spotted Fever, what is the organism? Rickettsia rickettsii. The answer is Rickettsia rickettsii, the causative organism. And the most severe form, see, you will be having such a kind of skin lesion in all rickettsial rashes except Q fever. In all rickettsial rashes, skin rash can be seen. And the cutaneous vasculitis is because if this is a blood vessel and these are the endothelium of the blood vessel, if rickettsia comes here, rickettsia is like a screwdriver. It drills a hole into the skin. It drills a hole into, it drills a hole into the endothelium. So it injures the endothelium and make the endothelium bleed. That is why they are painful eruptive vasculitis. They are painful eruptive vasculitis in case of rickettsia. Because pain was not given in this area, there is a very good chance you can confuse yourself between meningococcus and rickettsial infection. But this is definitely not by Coxiella burnetii. And if it is Rocky Mountain Spotted Fever, it is spread by what? Come on, people, tell me. Rocky Mountain Spotted Fever is spread by what? Anybody? It's spread by the bite of what? Excellent, Apurva. It is spread by hard tick. So you can expect the Rocky Mountain Spotted Fever to be spread by tick. So D is also wrong. Now why C is wrong? 10% of cases have the rashes on the extremities which are hemorrhagic is not true. Why? Because it is 90%, extremely high. If it is Rocky Mountain spotted fever, if I pick up 100 people suffering from Rocky Mountain spotted fever, more than 90 of them will be suffering from extremities rashes which can be hemorrhagic. So this is a hemorrhagic rash. This is a case of Rocky Mountain spotted fever. This is a rickettsial infection, and this is actually spread by tick. All these are features I would want you to know. Shall I zoom this picture for you? Yes, shall I zoom this picture for you? This is how it looks. Petechial lesions of Rocky Mountain spotted fever on lower legs and soles of a young, otherwise healthy patient. This patient will be young and otherwise healthy. There is no other comorbidity. And this is purely because of the combination. See, whenever you see a rash, it is because of the, now this point, if you notice, it is the bite of the vector point. Vector is biting it, that point. And the surrounding area is because of the response shown by the skin and also by the bleeding coming into this local area. So this is Rocky Mountain spotted fever. Excellent. Thank you very much. Now let's go for the next question. Look at the picture here. Pick up the true statement from the given picture. So first, again, do the routine, make a diagnosis, and behind the diagnosis, look for the causative. And after knowing the causative, think about the features of the causative agent in terms of pathogenesis and clinical features. Then come for the answer here. Pick up the true statement. 1, 2, 3, 4. 1. A relatively common bacterial infection. 2. Involves deeper layers of the skin. 3. It extends to the superficial lymphatic vessels within the skin. 4. Features are raised, well-defined, tender, bright red rash, typically on the face or legs, but which can occur anywhere on the skin. Among the following, which is the true statement? 1, 2, and 3, 1, 3, and 4, only 2 and 4, only 2, only 3. Which one? I'll give you 60 seconds time to crack the answer. No, Harshal, it is not lupus erythematosus. Excellent. Okay. See, don't give me numbers as your answer. Give me your answers as either A, B, C, D, or E. Okay, Kishore says ye. Deepika Ravi says ye. Aijaz Ahmed says C. Hemendra Singh says A. Abdul Yusufzai says ye. Aishwarya Karthikeyan says ye. Apurva Singh says D. Prakash Yadav says B. Shobhan says B. Sanjay says ye. Krishna Kumar says C. Durai Ravishankar says C. Okay, excellent. So let's log the answer. Okay, let me erase the annotations here. Let me log the answer. The answer is B. 1, 3, and 4. Why? Because option 2 is the response 2 is the false statement. Now, all of you have already known the diagnosis. There is Erysipelas, and Erysipelas is a direct attack on the superficial area of the skin. The most important keyword is superficial part of your skin plus that of lymphatics. That is negating the concept called as involvement of deeper layers of skin. I repeat, Erysipelas are not known to attack deeper layers of skin. It is known to attack only superficial layers of the skin. And Erysipelas are most commonly caused by Streptococcus pyogenes group A organisms. I repeat, it is caused by Streptococcus pyogenes group A organisms. So it is a relatively common bacterial infection, absolutely true. So A is a true statement. And extends to the superficial lymphatics within the skin, true statement. And please remember, even though you look at it in the skin area which is giving you a pink colored lesion along with the lymphatics, please remember they can be well defined. Now watch very carefully. Look at what I am drawing here. Can you notice it has been defined? It is not very diffuse. They can be controlled within a small area. The area of involvement can be noticed properly. So they are well defined, they are tender, and they are bright red rash. They can be present mostly on the face, but not necessarily localized only to the face. It can be present on the legs, but can occur anywhere on the skin. So option 4 is absolutely true. That is the definition for Erysipelas. So true statements are 1, 3, and 4. So I hope you will be able to use the information for your exams. So this is a case of Erysipelas. Okay, cellulitis is diffuse. Excellent. Thank you very much, Abdul Yusufzai. Now let's go for the next question here. See, remember, they are warm plaques. You cannot say whether it is warm or not, but you can say there is redness. When there is redness, there is inflammation going on. And if there is an inflammation going on, see, when you feel it, the redness may be because of the direct skin involvement, or it may be because of blood vessels underneath it. So if lymphatics are involved and they dilate, the blood vessels are slightly irritated, they are dilating, then only you can have warm plaques. If the skin epidermis alone is involved, then you will not be having warm plaques, there will be only cold plaques. So there can be erythematous and warm plaques. Now look at this. A 23-year-old male had unprotected sexual intercourse with a commercial sex worker. 2 weeks later, he developed a painless, indurated ulcer on the glans that exuded clear serum on pressure. Inguinal lymph nodes in both groins were enlarged and non-tender. The most appropriate diagnostic test is what? Go for the answer, people. A, B, C, D. Which one? Okay, correct. It is chancre. We all know this area tells you about chancre. Okay, what is your option here? Excellent. So everybody is on the same page. You are able to say it is B. So nobody has chosen anything else. Please understand, this is not a problem of HIV infection, but the most appropriate is the keyword. See, for the given picture, you are looking for the most appropriate diagnostic test. It has to be dark field microscopy of the ulcer discharge. Why not gram stain? Please remember, Treponema pallidum is actually a refractile organism. Can you name a structure which is refractile? See, in terms of a bacteria or an organism, I can say Treponema pallidum is refractile. Can you say a structure that is refractile? The structures which are refractile are flagella. Okay, excellent. Flagella. No. This is not lymphogranulum venereum. Please understand, this is not LGV. This is a classical case of your chancre, and the theory also suggests that unprotected sexual intercourse of a commercial sex worker, 2 weeks later, painless indurated ulcer. These are indurations that you see everywhere and they are painless. Both the chancre and the lymph node, chancre, both of them are painless. If it is inguinal lymphadenopathy of the LGV, lymphogranuloma venereum will be painful. Okay, that is why we go for chancre. Treponema pallidum is refractile. Flagella is also refractile. So, in both, the flagella can be visualized, Treponema pallidum can be visualized by dark field microscopy, and gram staining will not be essential. Why? Because why not gram stain? Gram stain is not staining this organism because it's extremely small. The most smallest of all spirochetes is Treponema pallidum. It can't be stained. And ELISA for HIV is not needed. JIPMER stain will be done for Leptospira, possibly, but most commonly JIPMER stain is done for Borrelia. I repeat, the JIPMER stain is mostly done for Borrelia, while gram stain can be done for non-spirochetal organisms. So the right answer would be dark field microscopy of the ulcer discharge. Different lesions on genital ulcers, the trick. Let me tell you one simple thing just about the lesions here. If it is chancre, it is painless. If it is chancroid, the key word you see is extremely painful, but no systemic manifestations. No systemic manifestations if it is chancroid, which is caused by Haemophilus ducreyi. And this is so painful that it bleeds to touch. It bleeds to touch. Next, you can think about HSV infections. These are the most painful of all the genitalia lesions, and they show systemic manifestations. Systemic manifestations. And in case of lymphogranuloma venereum, you can expect bubo, the ones lymph nodes which are filled with fluid. And the bubos, you can remember one thing. How do you differentiate lymphogranuloma venereum? The lesions will appear first. When the lesions are there, no lymphadenopathy. After the lesions have disappeared, there will be lymphadenopathy. So, no coexistence. The lymphadenopathy and the lesions will not coexist. This is the simplest way of remembering all these things. I hope you can be using this for your exams. I repeat once again, if it's a Treponema pallidum induced chancre, both the chancre and the lymph nodes are painless. So you keep this whole thing away. You don't have to confuse chancre with anything else. All the remaining things are painful. In terms of chancroid, it is painful, but when they use the word bleeding to touch, it has to be chancroid. then you can think of no systematic or systemic manifestation. The whole body, nothing else will be involved in case of chancroid. But if it is HSV, you can expect systemic involvement. In case of lymphogranulonarium, lesions come first, then disappear. Lymphadenopathy comes and then disappears. Both of them don't coexist. This is enough for answering almost all the questions about genitalia lesions. Okay, now look at this. What can you speak about this picture? Thank you very much, all of you. Yes, what is the diagnosis here? Thank you, Shobhan Mandal. Thank you, Duri Ravishankar. What is the diagnosis? It is not psoriasis. Clue, caused by Treponema pallidum. We are still not done with Treponema pallidum because that itself can cause a skull lesion. No, this is not phenoderma, this is not psoriasis, this is not chickenpox, this is not fixed drug eruption. So, what you are seeing here is secondary syphilis, papulosquamous truncal eruption. This is papulosquamous truncal eruption. Don't worry, you will not get spotters in your NEET exams. NEET exams are not just spotters. They should give you some kind of basic history, right? So that is why I gave you a clue. The causative organism is Treponema pallidum. But this is more than enough to show that this is a papulosquamous eruption. Yes, they are most infectious. This stage, excellent. This is the stage, patient is maximally contagious. Maximally, this is the stage where the patient is maximally contagious. Are you all liking these pictures? Are you all happy with the pictures and the lesions? Are you feeling good about learning a lot? So let me look at all the pictures once again from the beginning, just for the sake of people who have joined just now. So this is a case of erythema infectiosum and subitum, and here you have HHV6. This is a case of slapped cheek appearance, and these will be for lacy reticular pattern on the right side that you're seeing. This is seen in case of Parvovirus B19. I've discussed about the features and how to differentiate them. Then you can look at rubella. In case of rubella, incubation period is more than 14 days, so it is not less than 10 days. You can look at the discussion later. This is about primary HIV infection causing papillomacular lesions. This is possible. Many times we don't expect the HIV lesions to actually have lesions at all. So look at this. This is fixed drug eruption or exanthematous drug eruption, and this is about the rose spots, and we were looking at the question. Amikacin is not used because it will not be treating intracellular infections, and this is about SLE, and this is about the impetigo contagiosa caused by Staphylococcus aureus. This is about the rickettsial Rocky Mountain spotted fever, and this is the zoomed in portion. This is the Erysipelas caused by Streptococcus group A, and this is about the primary chancre, and these are the papulosquamous eruptions that you can see in case of syphilis. Thank you very much. Shall we do 2 more pictures if you'd like it? See, I have gone past my 1 hour time. I have gone beyond that time, and I'm really thankful for all of you who have been very patient in sitting and listening to me. Shall we do 1 more picture? Shall we do a few more pictures? Only if you like it. Before we wind up, I have gone past 1 hour period of time. Is it okay? Yes. What is this? Diagnosis. Thank you all of you. Thank you all of you. Yes, what is the diagnosis, people? Akash Trivedi says HPV. Yes. Anything else? Okay. Abdul Yusufzai says Watts. Shobhan Mandal says Watts. All of you are saying HPV, HPV, HPV. Excellent. So all of you are saying it is HPV, and you are saying they are Watts. If you are saying Watts, you divide them into 2 types of Watts. One is simple cutaneous Watts on the fingers and shoulders. For example, if you are involved in a non-protected sexual intercourse, there is a concept called as non-genitalia based sexual intercourse. For example, fingering can be a method by which a person touches the genitalia that is infected, and that finger may have some kind of warts. You don't even need that. For example, a person is suffering from finger warts and another innocent person is giving a handshake, that can also be causing finger warts. These can be caused by HPV 1, 2 and smaller numbers. When you go for warts, you can call them as anogenital warts, where you speak of 6 and 11 coming into picture. Here we can speak up to 4. 6 and 11 can cause anogenital warts, and you can speak of 16 and 18 which can cause it can cause cancer in the cervix. But sad to say, this is not HPV. This is not Condyloma acuminatum. You're speaking about Condyloma acuminatum, right? This is not a case of Condyloma acuminatum. Let me erase all the annotations. You all were hoodwinked. This is Condyloma latum. Condyloma latum is actually happening later after the primary stage. It happens in the secondary syphilis. How do I know it? Look at the lesions here. These all are looking wet or dry. You tell me, people. You tell me, these are not verrucous. They are not HPV. This is secondary syphilis. Tell me, these are wet or dry. What do you notice here? Excellent. All of them are, yes, all of them are wet. These are wet. When they are wet lesions, they are Condyloma acuminatum. Sorry, Condyloma latum. I'm so sorry. They are wet lesions. They are Condyloma latum. Why did I show you this? Because when you see Condyloma latum, you can mistake it for acuminatum. When you see acuminatum, you can mistake it for latum. So in this picture, watch it very carefully. All these things are shiny, at least semi-wet. They are not dry. Look at this. All of them are open lesions, highly contagious. Now, shall I show you Condyloma acuminatum? Shall I show you Condyloma acuminatum now? I'll show you. Yes, look at this. These are moist and somewhat verrucous intertriginous plaques, but these are called as the condyloma. These are giant condylomata. Giant condyloma acuminata. And these are absolutely dry. Don't get confused because they have used betadine solution here. Betadine solution has been used. That is why it is looking wet. Otherwise, they'll be dry. And these are called as oral condyloma acuminatum. Condyloma acuminatum. Now, can you notice these all are verrucous? They're coming out like cauliflowers. Can you notice this? Yes, Mukesh Goswami, please don't be scared. These pictures can be scary. So this is Condyloma lata and this is Condyloma acuminata. This is happening in the genitalia while this is happening in the oral cavity. These are the lesions that you can be seeing on the oral cavity, and these are verrucous, extremely verrucous. So let me erase using the eraser here. Can you notice these areas? Yes, they should be enough to show you how exactly it happens. Okay, now can you tell me what these are? Yes, diagnosis. Okay, palmoplantar warts, arsenic poisoning. See, in arsenic poisoning, you should be seeing some kind of whiteness, right? These are what you see as target signs. Target signs on the palm happening. Excellent. Raindrop pigmentation. No, these are not raindrop pigmentation, right? Faizan Zargar, I am very happy you came so closer. Watch these things carefully. They are not looking like raindrop patterns, but they're looking like target signs. This is seen in case of secondary syphilis. Others can have a differential diagnosis. Arsenic poisoning can come so close, but arsenic poisoning is not arsenic poisoning, not dark lesions. These are dark lesions and these are secondary syphilis signs, and they can be painless. These can be painless. Okay, now can you notice this? Yes, excellent, excellent, Harshal Rasania. You can look at the wrist and the ankles. Can you see the wrist also is involved in this area? Let me tell you just one thing. When a patient is suffering from primary syphilis, the whole world has no idea that he has primary syphilis except the patient. The patient knows he has primary syphilis because his lesions are confluence only inside the genitalia. So the genitalia lesions, unless the patient exposes genitalia, nobody will come to know that he has syphilis. But in secondary syphilis, the patient's genital lesions have disappeared. So if he's an ignorant patient, he thinks that the genitalia lesions have been disappearing, so he will be happy that there is no more syphilis, but they will re-emerge on the palms and soles as secondary syphilis showing target signs, and these are papillary areas, maculopapillary areas, which are actually being seen by everybody in the world. So everybody will know he has secondary syphilis except the patient himself. That is the beauty of secondary syphilis. Please remember, 25% patients can go for secondary syphilis, and again 25% people can go for latent lesions, but primary lesions disappear without any kind of treatment. I repeat, primary lesions disappear without any kind of treatment. So I have discussed as many pictures as possible. So for those people who have joined just now, do not worry, this videos will be available online forever, and we have discussed a lot of pictures here. You can go back and look at them, and I have personally done a complete course on microbiology and biochemistry, and this is the revisathon for those people who would love to attend my live classes. And for plus subscription, you can use my code Dr. ASM Live, where you'll get 10% discount on all the subscriptions, and you can have exclusive access to all my theory classes. For every class, I have backed you up with a lot of concepts. Every single line I tell you, I will give you the concepts. So if you could like to join Unacademy and take a plus subscription, please use the code Dr. ASM Live, so that you'll be having access to all my plus classes for both biochemistry and microbiology. And thank you very much for everyone for being very patient. Have a great life. I'll meet you again in the month of March with my plus classes and my special classes. And my special classes will generally be at the time 7:30 p.m. I'll be giving you announcements on my Telegram channel. In my Telegram channel, you can search by using my name, Meenakshi Sundaram AS. So I hope you'll be having a great exam. Thank you very much, all of you. Thank you very much, Abdul. Thank you, all of you. Thank you, Prakash, Vikas, Kanchana, Ankita, Kishore, Prakash, Ado, Sayantam, Ramu, Shobhan, Ambika, all of you, Mozam, Haider, everybody. Thank you very much. Thanks a lot. Good night. Let's stop. I'll see you again in the month of March at 7:30 for special classes. Use my code Dr. ASM Live if you'd like to subscribe. Bye-bye. Good night. Thank you.